Thank you for the opportunity to talk to you this morning. I apologise that my health does not allow me to travel to Boston, but from Melbourne, Australia, travelling to anywhere in the Northern Hemisphere is a long way. It is now 16 years since I went to see my family doctor for a checkup. It had been a while since I had had one, and I was in my early 50s. I learned two things. The first was that a digital rectal examination does not involve the use of a computer. And the second was that I had prostate cancer. As it turned out, it was an aggressive cancer. In the intervening years, I have had countless interactions with the healthcare system, including radiation therapy, chemotherapy, and systemic therapy. But more importantly, I have taken on the role of patient advocate and policy advisor, including chairing a state and then national cancer, as well as participating in numerous advisory panels. So I can look back over 16 years of therapy and living with cancer, and from almost as long as a patient advocate and policy advisor. So when I think about the question posed to me by ICHOM, what do patients want from their healthcare providers? It is with that background. To respond to this question, there are three primary points I would like to make. We want you to respect our intelligence and ability to make decisions based on what matters to us. We want to be treated with dignity. We want our families, carers, and loved ones to be included in our care. The first point is that we want you to respect our intelligence and ability to make decisions based on what matters to us. A friend of mine, who had been a cancer patient for 40 years, used to say, "No one should go into a hospital not knowing what is about to happen to them." Not all of us have PhDs or MDs, but I believe that it is our right to have it explained to us why we are going to have surgery, or lie under a big machine in a concrete bunker, be given that tablet to take, or to be sitting in a chair in a chemotherapy ward. Being treated intelligently starts with helping us understand our disease and the expected consequences of its treatment, and this takes time. Remember that when we are in a doctor's room and hear the word cancer, everything else goes out of our mind. We need to sit down and receive a thorough education. We need anecdotes and explanations, though it's not always you that needs to provide them. In December 1998, I had been on Zoladex, a medication that decreases one's testosterone level, for 3 months. We were in the middle of a shopping mall with all the Christmas tinsel around us, and I took hold of my wife's hand, and she very gently said, "Do you realise that that is the first time in 3 weeks that you have touched me?" I was devastated. We had been happily married for nearly 30 years at the time, but no one had told me that loss of libido meant that not only were you not interested in sex, but also you were not aware that you were not interested in sex. In addition, no one had told me that there would be a personality change on Zoladex that would affect my short-term memory and cognitive functioning. It not only affected my relationship with my wife, but it affected my ability to work as a university lecturer. Being treated intelligently also means helping me make decisions based on my values as a patient. You see disease as something to be treated. You see something that needs to be conquered, eradicated, and you may overemphasise the benefit of treatment and underemphasise the harm. We see it as something that affects who we are, our lifestyle and our relationships. We must live with both the benefit and the harm. And although we certainly value more time with those we care deeply about, we want that remaining time to be meaningful. For me, this trade-off was paramount when I was debating the first treatment for my prostate cancer. I knew that possible side effects of prostate cancer treatment were incontinence and erectile dysfunction. I didn't want either. But having spoken with people who had been treated, I got the message that erectile dysfunction was a problem when you wanted to have sex, but incontinence was with you 24 hours a day and 7 days a week. So I discussed these outcomes with my urologist. He asked me questions about my lifestyle, what I did for recreation, the importance of physical fitness, and so on. He had tried to get an idea of who I was, my values, and what was important to me. I still remember him saying after the positive biopsy result came back, and he made the recommendation that I have HDR brachytherapy and external beam radiation therapy. If you were not going to the gym regularly and not sailing that single-handed high-performance racing dinghy each Saturday afternoon and were 10 years older, then I might recommend something different. After my treatment, I was fortunate to be able to continue these activities for over a decade. For the most part, I have been fortunate and treated as an intelligent adult. I still have the piece of paper with a drawing of the male pelvic anatomy on it, lots of circles and scribbles, my proposed treatment and the words 15 years given to me following one of the early consultations with my urologist. My hope is that real outcomes data will help many more patients have candid conversations with their doctors about their options, their prognoses, and then to make decisions that are consistent with their values. Let me move to my second point. We want to be treated with dignity. When you receive a diagnosis of cancer, your life changes completely. There is not a day that goes by when you don't think about it. It is like a room in the back of your mind in which a shadow lives, and at times you feel as if you are frantically nailing planks over the door to keep that shadow in. In this state of mind, it is easy to let the disease take over your identity. And countless trips to the clinic or hospital only reinforces this mindset. But we are not a person attached to a prostate cancer. We are a person with a prostate cancer. And dignity is getting this order right. Respecting first and foremost who we are as a person before our biological state. Dignity also encompasses modesty, if you don't mind me adding a particular point. I am more than willing to run a campaign against backless gowns. I do not think it beyond our capability to come up with something that does not put those parts of our bodies that we like to keep private on display. Finally, dignity means respecting that we as patients live with our disease and have to manage everyday life. We often find ways of doing things that may not make sense to you. We might not know much about biology or pathology of disease. But if we find something that works for us, listen to us, take note as it might work for someone else, and do not tell us to stop unless you have a good alternative. And now to my last point. We want our families, carers and loved ones to be included in our care. I am a grandfather, husband, father and friend. Like me, every patient is surrounded by people who love and care about them. Our disease affects not only us, but all those around us. It affects them emotionally, spiritually, sometimes physically, and certainly financially. In my case, I retired early from my position as a university lecturer. That meant my superannuation, which my family was planning to rely on when I retired, was reduced significantly to what it might have been if I had retired normally. Likewise, if a carer has to give up work or reduce their working hours to care for a patient, there is a significant loss to them. And as I discussed earlier, side effects of treatment will impact family dynamics. After treatment, the patient may not be the same person as before treatment. So please make space in your treatment of your patients for their loved ones to be part of the journey, to make decisions together and to help them bear each other's burdens along the way. May I close by sharing my hope for all of you gathered today in Boston for this ICHOM conference. I hope that when you hear the word outcome today and in the future, you see more than a medical term or a statistic. You think of the millions of patients like me for whom that term means something very real, something that they live with every day. I urge you to track those outcomes for your patient, to use this data to help them manage the complexity of their condition, to use this data to compare patient outcomes with your colleagues nationally and internationally, and to use this as a basis for improvement. As patients, we need you to stand up and take on this challenge and have true patient-centered treatment. I wish you all the best in this important endeavour, and thank you.